Neonates can be classified based on gestational age as preterm, term, and postterm, and also based on birth weight as extremely low birth weight, and normal birth weight, and also gestational age and the birth weight combined. Small for gestational age, appropriate for gestational age, and large for gestational age. In this topic, we'll discuss about small for gestational age infants. Infants whose weight is less than the 10th percentile for gestational age are classified as small for gestational age. Gestational age is loosely defined as the number of weeks between the first day of the mother's last normal menstrual period and the day of delivery. More accurately, the gestational age is the difference between 14 days before the date of conception and the date of delivery. The Fenton growth charts provide a more precise assessment of growth versus gestational age, and there are separate charts for boys and girls. Even though some people use SG and IGR interchangeably, small for gestational age are not the same as that of intrauterine growth restriction. They are different. Small for gestational age are normal constitutional small babies or genetically small babies plus growth restricted babies. SG is diagnosed after birth by pediatricians using gestational age for newborns based on gestational age for their weight. SG does not differentiate between normal biologic growth potential and a pathologic or growth restricted state in utero, whereas IUGR is always a pathologic issue. It is diagnosed by obstetricians by at least measuring fetal length twice in utero. So IUGR is diagnosed by obstetricians based on at least 2 fetal measurements, and it is always pathologic, whereas small for gestational age is it's diagnosed after birth, and this can be normal. That means it can be genetically small babies, or it also includes intrauterine growth restricted babies. IUGR might be a normal fetal response to nutritional or oxygen deprivation. Therefore, the issue is not the IUGR, but rather the ongoing risk of fetal malnutrition or hypoxia. IUGR is often classified as reduced growth that is symmetric, or reduced growth that involves the whole body, head circumference, length, and the weight equally, or it can be asymmetric, with relative sparing of head growth. Symmetric IUGR often has an earlier onset in the first trimester of pregnancy, and it is associated with diseases that seriously affect cell number of the fetus. So symmetric IUGR is early onset. It affects fetal cell number. These are conditions with chromosomal, genetic malformations, teratogens, infectious, or early onset maternal hypertensive etiologies. It is important to assess gestational age carefully in infants suspected to have symmetric IUGR, because incorrect overestimation of gestational age might lead to the diagnosis of symmetric IUGR. Asymmetric IUGR is often of late onset, mainly in the second half of pregnancy. It demonstrates preservation of Doppler waveform velocity to the carotid vessels. This one is associated with poor maternal nutrition or with late onset or exacerbation of maternal vascular disease such as preeclampsia. Small for gestational age infants can be caused by a lot of issues. We classify them as fetal, maternal, and placental factors. Fetal factors include chromosomal disorders, chronic fetal infections, congenital anomalies, multiple gestations, insulin deficiency, and the like. Placental causes such as decreased placental weight, cellularity, decrease in surface area, villus placentitis or bacterial, viral, or parasitic infection of the placenta, infarction, placental separation, twin transfusion syndrome, and the like. Maternal conditions can be toxemia, hypertension, or renal disease, malnutrition, chronic illness, drugs, and the like. Despite their size, SG infants have physical characteristics and behavioral activity similar to those of normal-sized infants of like gestational age. However, they may appear thin with decreased muscle mass and subcutaneous fat tissue. Facial features may appear sunken, resembling those of an elderly person. The umbilical cord can appear thin and small, so you can identify small for gestational age infants by just looking at them from those of preterm infants. They are alert, they want to suck, they have spontaneous activity like that of term infants or like that of their gestational age, which is appropriate for gestational age. Their skin appearance, ear cartilage, and the sole creases are similar to that of their infants of like gestational age. Full-term small for gestational age infants do not have the complications related to organ system maturity that preterm infants of similar size have. They are, however, at risk of perinatal asphyxia, meconium aspiration, hypoglycemia, polycythemia, hypothermia. Perinatal asphyxia during labor is the most serious potential complications. It is a risk of intrauterine growth restriction is caused by placental insufficiency because each uterine contraction slows or stops maternal placental perfusion by compressing the spiral artery. Therefore, when placental insufficiency is suspected, the fetus should be assessed before labor and the fetal heart rate should be monitored during labor. If fetal compromise is detected, rapid delivery often by cesarean section is indicated. Meconium aspiration may occur during perinatal asphyxia. SG infants, especially those who are post-term, may pass meconium into the amniotic sac and begin deep gasping movement. The consequence aspiration may result in meconium aspiration syndrome. Meconium aspiration syndrome often most severe in growth restricted or post-term infants because the meconium is contained in a small volume of amniotic fluid, thus more concentrated. Hypoglycemia often occurs in the early hours and the days of life because of lack of adequate glycogen synthesis and thus decreased glycogen stores and must be treated quickly with IV glucose. Polycythemia may occur when SGA fetus experience chronic mild hypoxia caused by placental insufficiency. Erythropoietin release is increased during this time, leading to increased rate of erythropoiesis, and the neonate with polycythemia at birth appears ruddy and may be tachypneic or lethargic. Hypothermia may occur because of impaired thermoregulation, which involves multiple factors including increased heat loss due to the decrease in subcutaneous fat, decreased heat production due to intrauterine stress and the depletion of nutrient stores, and also increased surface to volume ratio because of small for gestational age. SG infants should be in thermoneutral environment to minimize oxygen consumption. Management of SGA newborns are generally supportive care and also maintenance of body temperature, early and adequate feeding, correction of those complications that we have said above, such as hypoglycemia, hypocalcemia, polycythemia, and the like. If asphyxia can be avoided, neurologic prognosis for term SG infants is quite good. However, later in life, there is probably increased risk of ischemic heart disease, hypertension, and stroke, which are thought to be caused by abnormal vascular development. If intrauterine growth restriction is caused by chronic placental insufficiency, adequate nutrition may follow SG infants. It allows them to demonstrate remarkable catch-up growth after delivery. Infants who are SGA because of genetic factors, congenital infections, or maternal substance use often have worse prognosis, depending on the specific diagnosis. Thank you for watching.